Okay, I am very happy to be here today to introduce you to a special speaker. This is session number 255, and it is going to be regarding the use of Thyrogen versus T4 withdrawal to prepare for radioactive iodine treatment or scans, and or for stimulated thyroglobulin testing with or without scans. Today, our special speaker is Sarimar Salgado, MD. She's an oncologic endocrinologist at Moffitt Cancer Center in Tampa, Florida. Dr. Agosto Salgado's clinical interest centers on the management of thyroid nodules and all stages and types of thyroid cancer, including administration of systemic therapies for aggressive tumors. She is also interested in the management of hereditary endocrine neoplasia disorders, pituitary tumors, adrenal tumors, adrenocortical carcinoma, and I'm not going to be able to, maybe you can help me pronounce that next one.
Pheochromocytomas and paragangliomas.
Okay, thank you. Her research interest focuses on intermediate high-risk thyroid cancers in terms of management, surveillance protocols, targeted therapies, and potential redifferentiation of tumors resistant to radioactive iodine. And with that, we're going to let the doctor go ahead and make her presentation. I'd like to introduce you to Dr. Salgado.
Thank you for your kind introduction, Becky. It's really an honor being here with the community of ThyCa as an oncologic endocrinologist, and also as a relative of a loved one who battled with thyroid cancer. I am really honored to be here and be able to share some perspectives this afternoon in terms of the use of Thyrogen versus withdrawal in preparation for radioactive iodine administration. These are some of my disclosures in terms of participation with pharmaceutical companies, whether in advisory boards, research, and committees, participation at different associations. And this talk may include the discussion of investigational therapies. The objectives of today's talk is to understand the different preparation modalities for radioactive iodine administration in differentiated thyroid cancer, or DTC. Review the risks and benefits of each modality, discuss the possible indications of diagnostic whole body scans as part of surveillance protocols, and review perspectives on the possibility of these approaches in the redifferentiation of differentiated thyroid cancers. For those of you that are early in the journey, just diagnosed maybe by a biopsy or a neck lump, I wanted to go through some concepts that might lead in the beginning of the journey. It's very important that the general preoperative workup includes a comprehensive neck ultrasound that evaluates all the cervical levels of the neck. We all have many lymph nodes. They're part of our immune system, which is part of our army that fights viruses and bacteria. But it's the most common place where thyroid cancer can spread to, and it's essential to have that as part of the evaluation of thyroid cancer. It's very valuable to also have a preoperative voice assessment, evaluate thyroid function test, and of course, if there's any suspicious lymph nodes, to biopsy, as that can affect the extent of thyroid and neck dissection, plus or minus neck dissection surgery. And when we biopsy thyroid nodules, of course, there could be several cytologic results or things that a doctor can find under the microscope when they're reading that biopsy. Most of the times, the patients that end up in surgery are either patients that have a benign biopsy, but where the tumors are too big in the neck, causing issues swallowing or problems with their voice. Definitely, if there is a suspicious for malignancy, those patients also are offered standard of care thyroid surgery. And intermediate categories where biopsies have been read as atypia or follicular lesions of undetermined significance, or what we call follicular neoplasms, in the era where molecular testing, meaning trying to find if the nodule has any abnormal genes that are associated to thyroid cancer, might help determine if there is a need of a partial thyroid surgery versus a total thyroid surgery. Of course, each case is individualized based if there is any presence of bilateral nodules and additional factors of your medical history. Thyroid stimulating hormone, it's a hormone that comes from our pituitary gland, which is a master gland in the brain that controls a lot of functions. And that thyroid stimulating hormone, or TSH, goes on to the thyroid to stimulate the thyroid to produce thyroid hormone in the form of thyroxine, or T4, which the body converts in the peripheral tissues to T3 or triiodothyronine. And after surgery, when somebody has their total thyroid removed, they will need to be on lifelong thyroxine replacement, which is commonly known as levothyroxine in the generic. There are several brand names. And most of the patients do well with just levothyroxine, but some patients we need to also supply the T3 in the form of Salgado. In patients that have had a partial thyroid surgery, there's an estimate between 30 to 50%, depending on the reference that you read, on needing a thyroid hormone supplementation after surgery. And it is very important to know that thyroid hormone medication will serve not only to replace the thyroid that is not in the body after it's been removed to surgery, because thyroid hormone is an essential hormone for the body. It helps function as in the brain, in the heart, and many organs in the body. But it would also be part of the treatment in differentiated thyroid cancer. As doctors, when we give a slightly higher dose than what the body will need, the body will sense that you have more than enough thyroid hormone, and that would send a signal to the brain not to send as much TSH. And so depending on where the findings of the surgery are and the risk of recurrence, we determine how low your TSH levels need to be. For differentiated thyroid cancer, which may include papillary and follicular thyroid cancer, which are the ones that I'm going to be focusing more. Sometimes we also include in this realm Hürthle cell thyroid cancers and poorly differentiated thyroid cancers, but those last two tend not to respond many times to radioactive iodine. So a lot of the focus of this talk is going to be mostly on papillary and follicular thyroid cancers. And after surgery, it's very important for us as doctors to review what we call the pathology report, which is the analysis where a doctor looked under the microscope the whole surgical tissue and is able to let us know how big the tumor was, if it was confined to the thyroid, if it was trying to extend out of the thyroid. And all of those factors are allowing us to determine what are the chances that surgery was curative, or do we need to do anything beyond that to hopefully reach a cure. We also evaluate at around 4 weeks after surgery something called the thyroglobulin levels, which is a blood work that we are going to be incorporating in your long-term surveillance. And what is thyroglobulin? It is a protein that is produced also by the thyroid cells, but that differentiated thyroid cancer cells, they still resemble that internal machinery that normal thyroid cells do. And they're able to produce that thyroglobulin. And once you have the whole thyroid out, we could use that as a tumor marker to see if there's any residual thyroid tissue or residual cancer left. Based on those two factors, we decide if there is need for radioactive iodine, which I'll be explaining further on. And as I mentioned, then the TSH suppression, which is taking the thyroid hormone medication at a specific levels that would also be part of the cancer therapy. The American Thyroid Association guidelines has proposed a risk of recurrence classification system, which helps us as doctors determine how intense we need to be with the monitoring, where do we need to keep the TSH levels, and if we need to do radioactive iodine or not. Radioactive iodine, it's utilized in differentiated thyroid cancer because the cancer cells still have that internal machinery that includes a pump or a gate for iodine in the border of the cells. And so we take that to our advantage and we prepare your body in a special way, which is going to be a big of the focus of this talk, to try to make those cells very avid or hungry for the iodine. But the studies have shown that for lower risk thyroid cancers, which may include tumors that are small, less than 4 centimeters, without a BRAF alteration, which is the most common type of genetic alteration in thyroid cancer, tumors that are microscopic, or very well confined to the thyroid, or if there's very small lymph nodes and there's less than 5 lymph nodes removed that were affected. In terms of being a very small metastasis, the studies have shown that those patients really their overall survival or risk of recurrence is not affected by receiving radioactive iodine. So generally, we don't recommend radioactive iodine ablation in those cases. We'll talk about certain scenarios where we might consider that. And then for intermediate risk cases where we find more than 5 lymph nodes involved, or where there was really a visible neck lump that the surgery could see, or we could see with radiographically what we call clinical N1. And for higher risk cases in those, it is definitely recommended to have radioactive iodine. Those cases we can see the tumors trying to extend out of the thyroid, or have more than 3 lymph nodes where the tumors were trying to extend also out of the lymph nodes. So I always suggest, when I started practicing in medicine, we didn't have yet electronic medical records. And even though now patients have access to their records through patient portals, it's not a bad idea to always keep a copy of your surgical pathology report and the operative note in case at some point you move and need to establish care with new doctors, that you also have all the information that's needed. And I would like to start the discussion based on a case discussion of note. This is a name that has been assigned by me so that we protect the privacy of the examples that we are going to be used today. And so let's call this patient Mr. Smith. He's a 65-year-old man that presented with multiple thyroid nodules incidentally during imaging at an emergency room after an unfortunate car accident. He also had history of hypothyroidism for several years, well controlled on thyroid hormone, high blood pressure, cholesterol problems, former smoking, and a prior history of colon cancer that was treated with surgery, and so far having been on remission. Of note, he had started noticing some discomfort swallowing foods. And when the nodules were noted on the CT scans that he had at the ER, afterwards an ultrasound of the thyroid and lymph nodes was ordered, which revealed that there was a 4-centimeter solid tumor, isoechoic, meaning the same color of the thyroid, on the right side, and a 2-centimeter thyroid nodule on the left side of the thyroid. Both nodules were biopsied, and even though the larger one was benign, the left nodule was on that indeterminate category, for which molecular testing actually revealed that there was a suspicion for cancer, raising that malignancy risk to 50%. And so given that he was having some discomfort swallowing, probably because of the thyroid enlargement and the suspicious contralateral nodule, the patient surgeon discussion led to having him undergo a total thyroidectomy. And it turns out that the smaller nodule had was truly cancer, a 1.8 centimeters classic PTC, not trying to extend out of the thyroid. Margins were clear, so very confined to the thyroid. In the background of what we call chronic lymphocytic thyroiditis, which is another name for the Hashimoto's or hypothyroidism that this patient had. Because the tumor is completely confined to the thyroid and it's less than 2 centimeters, we call that a T1, and he's considered a stage 1. And based on the risk of recurrence, that is between 1 to 2%. Postoperatively, although his TSH was above normal, his thyroglobulin levels were not too elevated, minimally detectable, but not very highly elevated. So by the American Thyroid Association guidelines, we could offer this patient active surveillance and obviously keeping the thyroid hormone levels for a TSH between 0.5 to 2. There is also certain cases if there is either a patient's preference or a provider's preference, if there's other risk factors in the history that would make benefit of having a radioactive iodine. There have been some very good control studies that have shown that for cases in around this category, what we call remnant ablation, which tends to be at a dose of like 30 millicurie, that's the activity of radioactive iodine dose, would be sufficient. And so what does RAI remnant ablation mean? It means radioactive iodine. And when we talk about remnant ablation, what we mean is that we're doing a low dose of radioactive iodine to likely kill any smaller remnants of the thyroid that were there, which may help facilitate the follow-up with thyroglobulin levels. As an oncologic endocrinologist, I'm comfortable following patients similar to this case with active surveillance, but there could be certain circumstances where we might lean them towards the remnant ablation. And so how do we prepare patients for radioactive iodine? So we prepare patients either by stopping their thyroid hormone for some time, which we call thyroid hormone withdrawal, or by giving injections of Thyrogen or recombinant TSH, which is the main focus of this lecture. The low iodine diet, as many of you may have heard, and ThyCa has a great cookbook that you should check out if your doctor is planning to administer radioactive iodine. It's very important because, again, we're trying to make, by raising up the TSH, either by stopping the thyroid hormone or by giving the Thyrogen injections, we're trying to stimulate that internal machinery of any remnant thyroid cell or thyroid cancer cell to be very avid to grab iodine. And by going on the low iodine diet, you're basically starving your body from iodine so that when you receive that pill of the radioactive iodine, it goes to those tissues that we want them to, which is any remnant thyroid cancer cell or any normal thyroid cancer cell that's left. It's very important to have a pregnancy test in women of reproductive age before. I typically, in my decision making about radioactive iodine, before even setting up the plan, I have a very good discussion with my patients, as I do tend to recommend not to get pregnant for at least a full year. Some doctors may go with 6 months. I'm a firm believer of 12 months. And in addition to that, we do tell them that if a woman is going to not receive radioactive iodine because she's planning on conceiving or she's actively breastfeeding, we also don't do radioactive iodine when somebody's breastfeeding. And our guidelines do say to wait at least 3 months after stopping breastfeeding before doing radioactive iodine. In that setting, I actually tend to prefer 6 months if the risk of recurrence allows me to wait around that time. We many times obtain a pre-therapy diagnostic whole body scan because if we find on that pre-therapy scan disease outside the neck, it might affect the dose that we are trying to give. And so that's the benefit of having a pre-therapy whole body scan. And then we receive the radioactive iodine dose and staying in isolation to avoid spreading the radiation to your loved ones and those around you. There's some restrictions about how long to travel by airplane, public transportation, how long to return to work. And there's a lot of individual factors that may affect that in terms of dose, kidney function. So always ask your doctor and your nuclear medicine specialist and your endocrinologist when you're cleared to be around your loved ones and go back to, quote, the normal life before radioactive iodine. It's also very important to remember not to miss the appointment of the post-therapy whole body scan, which is typically done between 3 to 5 days, some may extend it to 7 days after you receive your dose of radioactive iodine. And it is time sensitive. It's not something that we could do a month after you receive your radioactive iodine. And that post-therapy whole body scan is very important because it will tell us where were the tissues that were avid to grabbing that radioactive iodine. It's always good to keep a record of the treatment dose, both in case if you need additional treatments in the future, and also because metal detectors may actually go off for several months after your treatment. So it's always good to have a card that you received that therapy. Levothyroxine withdrawal, as I said, stopping your thyroid hormone, it should be at least 3 to 4 weeks before the radioactive iodine therapy or the diagnostic whole body scan. And sometimes because being off the thyroid hormone for that time may cause some symptoms of tiredness and symptoms of acute hypothyroidism, we could try to substitute on that early stage with Cytomel if we are going to be stopping the thyroid hormone for more than 4 weeks. But you should be at least off the Cytomel for 2 weeks before you receive the radioactive iodine dose. The TSH should be measured, and so far what it's been accepted has been to have the TSH above 30, either for therapy or for diagnostic testing. And the symptoms of stopping the thyroid hormone and being hypothyroid acutely may include fluctuations in weight, feeling more cold than usual, tired, difficulty concentrating, more constipated, dry skin. Sometimes you can note the voice being a little bit deeper or hoarse. Patients may experience also mood changes, depression, what we call periorbital swelling or puffy eyes. The heart rate may go also slower, which is something to also be taken into account in patients that have a cardiac history. And in the blood, some of the electrolytes, especially the sodium, can go low. I'll never forget a case. I was called one time to the ER for a patient that had a very low sodium. And when I went to evaluate her, she was having symptoms of the low sodium, and it was that her endocrinologist at that time was preparing her to receive radioactive iodine, and we had to stop the preparation and actually put her back on thyroid hormone medication quickly and keep her in the hospital until her sodium levels were better control. She was able eventually to receive her radioactive iodine therapy using the recombinant TSH or Thyrogen, which is basically injecting for 2 consecutive days a dose of 0.9 milligrams intramuscular of recombinant TSH. And on the 3rd day, you would receive the radioactive iodine dose, again, whether diagnostic or therapeutic, followed by the scans a couple of days after that dose, and also measuring the stimulated thyroglobulin levels. Now, we talked a little bit earlier about thyroid hormone withdrawal in terms of the potential side effects of having that hypothyroidism. stay on for several weeks in terms of the symptoms. And there are occasions when then patients have been stopping their thyroid hormone for some time, and when they're about to get ready to receive the radioactive iodine, the TSH is still not where we wanted, and we end up adding Thyrogen at that time to kind of help boost up the TSH. There could be also patients that whether to access to healthcare or financial circumstances might not be able to afford to receive the Thyrogen injections. And so that's why, depending on the setting where you are, some doctors might be doing, withdrawal more. Recombinant TSH has been a very advantage in the terms of that you are able to keep taking your thyroid hormone through the whole preparation of the radioactive iodine. And the side effects in reality tend to have been very minimal in my experience. The package insert does list some nausea, headache, very low % of fatigue, vomiting or dizziness, which in reality I have not seen much of those happen. But I wanted you to have all the information that that the company does mention. There have been also cases that when they receive the injection for the recombinant TSH, if there's a lot of remnant thyroid tissue remaining, or if there's system metastasis that could respond functionally, they could have a transient episode of hyperthyroidism. So we have to be careful if somebody's has a very strong cardiac history, maybe monitor those patients and obviously select very closely, one preparation versus the other. There is also a label that they do mention that depending on the tumor location, sometimes your doctor may consider giving you steroids before using Thyrogen if the tumors are very close to the airway. Because the tumor can enlarge transiently. That does not tend to happen, commonly. I haven't needed to premedicate anybody in my career. They do mention that obviously you have to be concerned if there is, if you know that there is disease at the areas where if the tumor gets swollen, there could be, problems, whether in the spine, areas like that. So a lot of the times, if I have high-risk patients before doing radioactive iodine, I may get different set of scans that would allow me to see where the disease is before I put them through withdrawal or Thyrogen. Again, each case is individualized. Let's talk about Mr. Diaz now, who has a little bit of a different presentation than the case we talked before. He has a history of prostate enlargement, and he self-noted a neck lump. We did obviously a comprehensive thyroid and neck ultrasound, which showed a 1.1 centimeter thyroid nodule that had higher risk features. It was darker than the rest of the thyroid, hypoechoic. It had very small microcalcifications. And in the lymph node mapping at what we call the level 6, which are the lymph nodes that are very close, almost below the thyroid, there was a 2.5 centimeter lymph node that you can see on the right of the page. Lymph nodes typically look much smaller and they only have a fatty center. You can see that this looks like a solid mass. So we had him see a high volume thyroid surgeon to minimize complications, and his surgical report showed papillary thyroid cancer, but under the microscope the cells looked more taller, and we call that tall cell variant, which might explain why there were lymph nodes involved at the time of the surgery. 5 of them were positive, and the largest one was that 2.6 centimeters. So with the staging in thyroid cancer, we divided in age above or less than 55 years old. In patients that are less than 55 years old, we have only stage 1 and stage 2. Stage 1 is thyroid cancer that's either just on the thyroid or on the lymph nodes. And stage 2, it's when it has spread beyond the neck. In ages above 55, we divided a little bit more. So he would be considered stage 2 because of the amount of lymph nodes that were involved. However, it's not that the stage is not important, but a lot of the times what I focus very much early on is on the risk of recurrence, because that tells me how aggressive I need to be upfront and how closely I need to monitor my patients. He had a CT chest non-contrast that didn't show any kind of evidence of bony lesions or lung nodules. And so the question is, should we administer radioactive iodine? And if so, under which preparation? And so this patient is going to that mid-category or intermediate risk of recurrence from the ATA guidelines 2015, where we should consider radioactive iodine in certain circumstances. A lot includes, what were those features on the pathology, what is the post of thyroglobulin, the patient's ability to follow up, and in terms of the concerns of goals of care, the physician's concerns, the other medical conditions. So a lot of things we weigh into that decision. But generally, with the tau cell variant, which likely is associated with that BRAF alteration that in some cases may cause eventual resistance to radioactive iodine, we tend to consider, giving that benefit of providing radioactive iodine earlier on. And so in patients, what the guidelines do say that for that intermediate risk category is that patients that are low risk or intermediate risk without extensive lymph nodes involvement, if you're planning to do remnant ablation, which is that dose to just kill any remnant normal thyroid cells present, or we're thinking about doing adjuvant therapy, which tends to be a dose between 75 to 150 millicuries, depending on your endocrinologist, overall assessment on your clinical scenario. We call that higher dose adjuvant therapy because that is ideally going to try to take care of not only any remnant residual normal thyroid, but it would also help eliminate any microscopic thyroid cancer cells that could be spreading on the neck. And what the guidelines say is that preparation with recombinant thyroid hormone or Thyrogen is an acceptable alternative to thyroid hormone withdrawal for achieving ablation, because we have seen that the studies show that there have been no major difference in terms of survival and prognosis of the patients, and the fact that because they seem to be the Thyrogen seems to be non-inferior, and patients do feel a little bit better of quality of life when they are on the therapy. When they are still taking basically their levothyroxine rather than stopping it for more than 4 weeks. However, in patients that are what we call intermediate risk differentiated thyroid cancer by ATA classification, who have extensive lymph nodes in the absence of cancer spreading outside the neck. Although ideally you would consider a withdrawal, it is acceptable to use Thyrogen as an alternative to the withdrawal prior to the adjuvant radioactive iodine therapy. And this data has come from studies that have looked specifically at those group of intermediate risk differentiated thyroid cancer patients that have significant lymph node involvement or that have other features that that may confer certain aggressiveness to the pathology. And when they have looked in terms of their overall prognosis, so far it seems to be acceptable. One of the main reasons why it says to be considered as an alternative is because most of these studies are basically us looking back at what has been done, because being able to do a study that what we call prospectively, meaning to actively enroll patients either in one or the other, would require a multi-center study in different places, will be likely quite costly and have a lot of variability in terms of the different presentations. So we have to, so far, work with the data that we have. I can tell you at most of the places that I have trained or work, which are centers that are very focused in thyroid cancer, we use Thyrogen quite frequently. And I have seen good clinical outcomes in the intermediate risk patients and even on the higher risk cases. So if you fall in that intermediate risk category and your doctor has prepared you to receive radioactive iodine with Thyrogen, it is actually a very widely accepted practice. And it's actually what my patient elected to, because his job, it's very mentally demanding. He's in a position where his decisions could affect the life of a lot of people, and that's why we did not want to risk having him being transiently hypothyroid for several weeks. And as you can see in the post-treatment scan, there was some mucosal uptake. He had negative brain imaging, so this is not any type of disease in the CNS. He did have neck uptake, and it does bring the volume of very important to stay very well hydrated through the process, because he had a lot of uptake in his bladder, likely because of the enlarged prostate. So we always tell patients to try to stay as hydrated as possible and to ensure that you're urinating frequently. Now, to move forward with a different case scenario, I have Mrs. Jones. Mrs. Jones, it's actually a young woman, age 36, who presented to us with thyroid nodules, which she actually presented to an outside endocrinologist first with thyroid nodules that were detected by her gynecologist during a routine examination. She also had a history of migraines and depression. And her comprehensive thyroid and neck ultrasound actually showed a large suspicious thyroid nodule and multiple left lateral lymph nodes that you can see on the images. These are her lymph nodes. And the pathology, so her surgery not only included a total thyroidectomy, but it also involved removing lymph nodes that are on the central neck, which is the area below the thyroid, and also on the left side of the neck. The pathology was papillary thyroid carcinoma, 4 centimeters, and it was trying to extend out of the thyroid. We call it extrathyroidal extension. It was invading lymph nodes, and out of 23 lymph nodes that were removed, 13 were positive, with the largest one being 2.1 centimeters. So that puts her at the very close area of the higher risk of recurrence by the ATA guidelines 2015 to a risk of recurrence of around 40%. And her post-operatively thyroglobulin levels were significant, were 21. And that's when she came to seek an opinion with me as an oncologic endocrinologist. And so we did additional staging imaging. We didn't see any remnant residual neck disease that needed surgery. There were no bony mets, no brain metastasis, but there were very scattered small pulmonary lung nodules. When she established care in my clinics, she explained to me that after she had her thyroid surgery, she had missed the thyroid pill for a couple of days, and she felt very weak. She was having brain fog, and her prior doctor had advised her to take her levothyroxine, every day. And as she started having symptoms, she went back to being very compliant, but it still was taking her time to adjust to life after surgery and was having significant fatigue. Her social circumstances include being a single mom, full-time working, and also being a part-time student. So she was very concerned about being hypothyroid and her symptoms exacerbating, being off the thyroid hormone, knowing that because of the long metastasis and the high risk of recurrence, radioactive iodine at a therapeutic dose is recommended. And so typically, what the guidelines do say is that in patients with ATA high-risk differentiated thyroid cancer, with a higher risk of disease-related morbidity and mortality because the cancer may have spread out of the neck, we still need a little bit more controlled data and outcomes, meaning follow patients that have received radioactive iodine with Thyrogen a little bit longer before we can strongly recommend that Thyrogen is, the way to go in that specific population. In patients with differentiated thyroid cancer at any risk level, even high risk level, that it's not really safe for us to do the thyroid hormone withdrawal because it can either exacerbate a medical condition, somebody that has already low sodium before starting the withdrawal process, somebody that has significant either cardiac or even mental conditions that could be acutely exacerbated and cause a significant adverse event, or somebody that tried stopping the thyroid hormone and it's really not getting to the levels that we need to be able to administer therapy. In those cases, it would be a medical decision to use for safety then the Thyrogen, and we should then consider it in those situations. However, in high-risk differentiated thyroid cancer patients where we still need a little bit more evidence, a lot of the times it's a patient-physician conversation. And as I mentioned, many of my patients we've treated comfortably with Thyrogen, and so far we've seen favorable responses. And if you go even to larger and dedicated thyroid centers, you are going to see Thyrogen being widely used. And it's not because we think of making everybody's life maybe a little bit easier. It's because we already have some data that supports that the trend is likely going to be favorable as we anticipate with Thyrogen, and I'll show you that data in a second. I wanted to show you that on my patient, after having a discussion, she elected to do the process with Thyrogen. She basically did not have any symptoms, and as we suspected, that thyroglobulin was likely coming from a lung disease, which was significantly showing uptake here. This symbol here is a marker, but we are going to be monitoring her very, very closely to see if there's any type of progression after the radioactive iodine, or if there's even benefit in the future of considering another dose after 6 to 12 months have passed from her initial dose. We did pulmonary function tests. She didn't have any obstructions and didn't have any complications from treatment. And so I was mentioning that there's some evidence that it seems to be promising in terms of the use of Thyrogen in the setting of high-risk metastatic disease, meaning patients with either papillary or follicular thyroid cancer, where it has not only spread to lymph nodes, but it has also gone into the lungs or the bones. So this study was done by a group in Italy, and even though it's a retrospective study, meaning looking back at their experience over 15 years, they did an excellent job in matching, as you can see on the tables, the patients that had been solely treated by either thyroid hormone withdrawal, which they call the hypo group, versus the Thyrogen group, which they call RHTSH. The numbers of cases were quite similar, and they were able to match them to extent of surgery, the type of thyroid cancer, stages, and risk of recurrence. And there were no significant differences between the group. So that was pretty amazing that they took the amount of detail to do that, to get the most pure information that we could get from this study. And the comparison of these two groups of patients showed that their outcome was very similar after following up for about 4 years, which is quite promising. We might need to look at, what happens a little bit longer than that. But the fact that we are seeing that for both groups, there was a percentage of patients that had a clinical remission, which were usually patients that only had disease in the lymph nodes. There was a small percentage that had biochemical disease, meaning positive tumor markers. And the majority of patients, many times what we see when thyroid cancer has spread outside the neck with radioactive iodine is that we see either slowing down the progression or at least a stabilization. And they saw that 91% of the patients had clinical benefit. The small curative response, meaning those patients that reach clinical remission, is in line with this data that has been reported, where patients with about 1/3 of the patients that have metastasis have been able to reach that remission state with radioactive iodine. Again, it's usually low volume, small lymph nodes involvement, and they saw that there was similar outcomes. Basically, the preparation with either Thyrogen or being acutely hypothyroid from stopping the thyroid hormone did not have any efficacy on the radioactive iodine. Although you might see here that the persistent structural disease, meaning the persistent tumors rate, was a little bit higher on the group that received Thyrogen, they clarified that when they looked into detail was that there had been a little bit more patients that had bone metastasis in the group that received Thyrogen. And we know that that bony metastases are very hard to disappear, basically with these treatments. And as I said, when they did very specific statistical testing, there was no difference between either preparation. So this is very reassuring, and this is, a lot of what supports why you might see oncologic endocrinologists treating high-risk thyroid cancers with Thyrogen. What about the use of diagnostic whole body scans? In the prior guidelines, patients received one treatment of radioactive iodine, and then you would have to do the subsequent years yearly whole body scans. And when you had basically 2-3 negative, the patient was considering remission. That's what was done in the past. Nowadays, if we are not seeing any clinical evidence in the tumor after patient has had received a total thyroidectomy, and we see very low serum thyroglobulin levels under suppression, less than 0.2 or less than 1 after stimulation, and you have a good negative neck ultrasound, you could consider that what we call an excellent response, and it's not necessarily needed to do the whole body scan. But if somebody does it and the patient already had received radioactive iodine and it's negative, then that's also another pointing towards what we call an excellent response. Now, in patients that we typically follow patients every 6 to 12 months in the beginning, depending on the risk stratification. For low and intermediate risk patients that you have that excellent response with the thyroglobulin and the ultrasound, it's not really needed to do a diagnostic whole body scan because they've had an excellent response to therapy. Now, subsequent either Thyrogen or withdrawal testing may be considered what we call patients that have had indeterminate biochemical or incomplete response. And I'll go into details of what that means. Basically, just to summarize, it's patients that still have a detectable thyroglobulin or tumor markers or tumor antibodies that are rising, or patients that still have some tumors left, and you want to see if they are still avid to radioactive iodine. So recommendation 66 of the ATA guidelines, what it basically mentions is that after the first post-treatment whole body scan, after low dose radioactive iodine, the remnant ablation, or the adjuvant therapy, which is between 75 to 150 for in low and intermediate risk patients respectively that have undetectable tumor markers or negative antibodies, you have an excellent response. And as I mentioned, you do not need to do the whole body scan. However, if you have still considering any high or intermediate risk features, or you have concerns of persistent disease, you could do a diagnostic whole body scan 6 to 12 months after the dose of radioactive iodine. Now, I want to make a big alert of caution here that individualization is key, because some of you that may be in the audience might be in this setting, and you might wonder why my doctor has not necessarily pursued doing a diagnostic whole body scan. And the reason is that individualization is key. Your doctor maybe maybe looking at the whole big picture and your overall response if your tumor markers are going down. If there's concerns of either thyroglobulin or antibodies going up, then other imaging modalities may be considered first, like CT scans. There's certain occasions that we incorporate a PET scan so that we can see where the tumors and measure them before we consider going back to exploring radioactive iodine. And the reason is because there could be a population of tumors that could be resistant to radioactive iodine and not really light up on a diagnostic whole body scan. And that's what we call RA refractory disease. In terms of the response, a lot of the times I see that patients focus a lot on their stage. And as oncologic endocrinologists, a lot of times we focus a bit more on the response. We have talked about that excellent response of low tumor markers and negative imaging. We see that the risk of recurrence then changes to 1 to 4%. So that's what we call a dynamic risk stratification, because you start with a risk of recurrence based on the surgery, but as we monitor over time, then based on what we see on the scans and the blood work, that risk of recurrence might change. And even in patients that have either rising tumor markers or that still have positive antibodies that are either going down or stable, which we call indeterminate response, the risk of dying from thyroid cancer is still low. It's still less than 1%. But if your doctor is still seeing tumor markers going up, you'll see that they might want to do again additional scans. Now, definitely when we know that there is tumors either in the neck or outside the neck, and regardless of what the thyroglobulin is doing, there might be, as we talked about, additional incorporation of other scans. So, so sometimes, as I said, it's important to look at tumors that we can see and measure before exploring for that radioactive iodine. And I know that this slide may look busy, but I'll walk you through it and I'll focus on several important key points. So all of this is actually this purple circle here, it's a tumor cell of thyroid cancer, that it has a lot of receptors, and so far for patients that have developed a metastatic thyroid cancer, that it's not responding to radioactive iodine and that we cannot keep under control just with keeping the thyroid hormone levels elevated. There have been different drugs that have been approved over time, and as an oncologic endocrinologist, I really hope that this slide continues getting busier and busier easier until the day that we have a cure. But the reason I wanted you to see this picture was, first of all, to those that are battling with more advanced cancer, to see that that there's hope, that there's a lot of us that are trying to think outside the box on how we can help you better and gain some time, but also to focus on this part of that internal chain of signals inside the tumor cell, where we can see that BRAF, which is the most common alteration in thyroid cancer, followed by RAS. And this chain of events here, it basically gets turned on constantly when there is thyroid cancer, if one of these two alterations are present, or if one of the other outside signals indirectly activates that pathway. And what that does, it basically starts shutting down those gates or iodine pumps on the thyroid cancer cell. And what we have seen is that sometimes if we do an oral chemotherapy called a MEK inhibitor, for patients that have a RAS alteration or a BRAF plus or minus a MEK inhibitor, we block this pathway of cell proliferation. We can see shrinkage of tumors, but we can also see that reactivation of those pumps of iodine being restored on the cell. And that is something relevant for patients that have radioactive iodine refractory thyroid cancer, or basically tumors that are resistant to radioactive iodine, which we diagnose when we know that there are tumors that never concentrated radioactive iodine, or if it was a tumor that before used to grab iodine and now we're not seeing it be able to capture radioactive iodine on a diagnostic whole body scan, when we see that some lesions grab iodine and others don't, or if after giving a good dose of radioactive iodine, we still see the tumors growing 6 to 12 months after the therapy, or if we see that the tumors are very bright on a PET scan, those are considered criteria for radioactive iodine resistant thyroid cancer. And
Dr. Salgado, I hate to interrupt. We're down to about 2 minutes or maybe 3 minutes. So we'll have to kind of wrap things up a little bit. And I wish we were going to have time for questions, but unfortunately, I don't think we will. But go ahead.
Well, maybe we can take a peek of what the questions are over here so far. It says here, with a lobectomy, does a raised thyroglobulin indicate need for RAI, or does half thyroid remaining affect the thyroglobulin level? Yes, so after somebody has half their thyroid removed, overall, we would still see detectable thyroglobulin levels, because the other side of the thyroid would be able to produce that, and it would still be a little bit controversial to have a designated number, but I tend to trend it. But there's been some data that that it's still, early on for us to know if we can use that. There's a question here in terms of redifferentiation process for 1 month, then I-131, which did not work, caused metastatic PTC to spread and grow, especially if Thyrogen was used. Basically, when we consider checking for those, if the BRAF or RAS alteration is present, and we have a patient that is not yet needing longer-term systemic therapy, but that you're seeing that slow progression, that's when your doctor may consider redifferentiation therapy. We test these tumors different ways, either by sending the whole tumor to get analyzed or staining it for that BRAF alteration. And there have been some studies that after being, as you're mentioning, 4 to 6 weeks on the therapy, some patients may actually capture radioactive iodine. I wanted to highlight that many of these studies have actually used Thyrogen, and so I don't think that the ability to capture uptake was the failure to capture uptake, in my opinion, would be related to the Thyrogen. And in fact, I think that it's going to be actually the preferred way, because as these even though these are oral chemotherapies that you take at home, they cause a lot of side effects, including high blood pressure, nausea, and so being being hypothyroid for a long period of time, it's going to be hard for doctors to figure out what is coming from the thyroid hormone withdrawal versus the chemo. So probably we'll keep those. And I see this other question that I see here, we also answered, which is Thyrogen shots using high risk of recurrence. I have answered a lot of these questions already. Timing between CT scans with contrast and radioactive iodine treatment. Some people suggest 6 weeks. I tend to wait 3 months. And especially if it's a higher risk case that you really want to give the whole benefit of that dose, I tend to wait 3 months if possible. Your doctor can also check urine iodine levels. If it is for redifferentiation, then we try to coordinate the timing of redifferentiation so that you have had some imaging that we know that things are not progressing while you're on the chemo, but at the same time not to interfere with the process. And I just wanted to see that this might show that the redifferentiation approach may be able to keep patients off needing systemic therapy for some time. There's actually some lectures here at ThyCa that are going to be more focused on that. I wanted to show an example of a patient where we did this successfully. And in addition to that, I see that there's another question about being treated outpatient in a behavioral facility for anxiety and depression and need a routine RAI and stimulated TSH. Would just say Thyrogen would be recommended. I've had excellent experience with Thyrogen in this setting. Actually, this picture that I'm showing you, it's actually a patient that was on a targeted therapy for 3 months, a young patient in her 20s that had lung metastases that were resistant to radioactive iodine, and we were able to redifferentiate. As you can see on the scan, we're seeing long optics. So, so if your doctors are just planning to do a routine scan, I would say Thyrogen would seem to be a reasonable option to avoid exacerbating any mental issues. In reality, Thyrogen is really well tolerated. I did want to mention to those of you that have read the package insert, besides the hyperthyroidism and the tumor enlargement, there's a small risk of stroke that is mentioned on the package insert that I personally have not encountered or have not actually heard from any of my colleagues occurring. So it seems that it has been something in cases that have very particular risk factors. So always discuss with your doctor if he feels that Thyrogen would be a safe alternative for you, because at least so far we are seeing promising data that the efficacy of radioactive iodine does not seem to be compromised. There is a question here. It says, I heard you say that in advanced cases, the use of Thyrogen was preferred because of keeping the symptoms manageable. Are there times where just eliminating thyroid meds is preferable? So obviously, there's a lot of, patient preference. If in advanced cases, when I meant was in the cases that are undergoing redifferentiation, because I have them already on an oral chemotherapy, I want to be able to delineate well what's a side effect from the chemo and what's a side effect from being hypothyroid. And for the redifferentiation to work, we believe that the patients need to be constantly on the chemotherapy for at least as early as 4 to 6 weeks. Sometimes it may be more if you have needed to do any drug holds or any pauses to give the patient to recover. So settings where you could prefer just stopping the thyroid hormone, I would say somebody that that had either Thyrogen in the past and had the concern of a potential allergic reaction, somebody where you can safely administer cytomel maybe for the first 2 weeks and have them feel better. I think in that intermediate category or the high risk patients, as long as you're sure that there's not any distant disease that needs to be treated and more urgently before even doing radioactive iodine, then you could consider withdrawal to safely. And for lower risk, either way seems to be comparable. All the studies that I've read, both preparations seems equally doable. So a lot of the times there would be just, your doctor looking at your cardiac history and your medical history, and to be able to make that decision very individualized.
Okay, we're down to just a few minutes. They gave us a few extra. So you might have time for one more really short question. There was one in the beginning that was asking if Thyrogen is preferential for people with chronic kidney disease.
Yeah, so chronic kidney disease, it's a scenario where there has to be, very good coordination also too within a nephrologist if you're on dialysis to coordinate the administration of the radioactive iodine and the dialysis so that the treatment, can be safely administered. The package insert does say that Thyrogen may stay a little bit longer on the system if the patient has, chronic kidney disease. At the same time, withdrawal can decrease the creatinine clearance. So I think probably because of all the coordination that has to undergo treating somebody with chronic kidney disease, where you might also talk with some doctors that even might consider even adjusting the dose given the clearance of the iodine in the system. It might be reasonable to consider Thyrogen, but again, your specific laboratories and circumstances need to be considered. So I would suggest to talk with your doctor and see what he feels will be safer.
Thank you so very much for sharing all of your knowledge with us this afternoon. In the meantime, I want to really thank you, Dr. Salgado, and I hope all of you enjoy the rest of the conference.
Thank you, everybody, for attending. To all the patients that along the way have entrusted their care between Florida, Puerto Rico, and Texas. This month is Thyroid Cancer Awareness Month. But as this very nice picture that I saw on the internet says, for me, it's also the whole year. As somebody that have seen this on a day-to-day basis, and also from the perspective of being seeing it, a loved one go through it, know that you have an ally on me. And if there's any questions, please don't hesitate contacting ThyCa, and they know how to contact me so that we can further clarify any of your questions. And I hope everybody has a beautiful week.
Thank you. You're awesome.